Ladies and gentlemen, welcome back to Step 3 High Yield. We're now in the nephrology section. Yes, kidneys, urine, bladders. We're going to be talking about a great deal of information here, starting with acute renal failure. Acute renal failure is something you're going to see very, very commonly on the wards, and Step 3 loves to ask you questions about acute renal failure because it's very, very algorithmic. It's very, very approach-oriented. Now, what we must keep in mind about acute renal failure is that there are three kinds of acute renal failure. The first is pre-renal, due to perfusion problems, most commonly hypoperfusion. The next is renal failure, meaning at the parenchymal level, at the level of the kidney. There's something wrong with the nephrons. There's something wrong with the actual kidney itself. The last type of acute renal failure is post-renal. As you can see right over here, post-renal. Now, post-renal failure is a little bit different because this is an obstructive process. There's something wrong with the filtrate coming out. We can't drain the kidneys. So to review, pre-renal, not getting enough blood to the actual kidney. Renal, something's wrong with the filtration process. And lastly, post-renal, we can't drain the kidneys. And these three forms can create acute renal failure. Now, acute renal failure lately has also been called acute kidney injury. But acute renal failure is the term that's really in vogue. Acute kidney injury has come and gone, and some people use it, nephrologists most commonly. But for your purposes on the USMLE Step 3, acute renal failure is the term that's going to be used. Now, clues to tell you that renal failure is going on and that it's of short duration are the following. Number one, that the kidneys are normal in size. It has to be acute because long-term renal problems will cause either large kidneys from, say, for example, protein deposition. Ooh, what disease causes protein deposition in the kidneys? Well, a lot of them can, most specifically amyloidosis. But an acute process, the kidneys don't have time to get bigger. Or what about chronic kidney disease? They call them small, shriveled kidneys. But that's also a chronic issue. Short duration, normal kidney size. The next is a normal hematocrit. Yes, a normal hematocrit. Remember, the kidney's perfusion lets it tell you, well, my kidneys tell me, hey, I know how much EPO to release. The stimulus comes in, oh, I'm going to release a little bit of EPO today. Oh, tomorrow I'm not going to release any of it. Oh, tomorrow I'm going to release a little bit more. And so what ends up happening is your kidneys maintain the homeostasis of your hematocrit. In an acute setting, your hematocrit won't change because the EPO levels don't have that strict, quick impetus to drop off. Your kidneys will still produce it for a little bit longer. The next is a normal calcium level. Calcium is very, very commonly the last electrolyte to be affected by renal failure. Now, chronic renal failure, the kinds that are not acute, will have kidneys that are smaller. They're hypoperfused, they're undernourished, they're itsy-bitsy. Erythropoietin production drops off very, very dramatically, and then you get a drop in hematocrit because you're not stimulating your bone marrow to produce red blood cells. And lastly, you have a drop in calcium level from the loss of vitamin D activation. So look at the differences here between acute and chronic. In acute, it's a fast, very, very rapid change in your BUN creatinine, and so therefore your kidneys stay normal, your hematocrit stays normal, and your vitamin D activation stays normal, and therefore you actually have no active signs of a chronic process. But in chronic renal failure, your kidneys aren't perfused properly, so they become smaller in size. And the hematocrit drops, so your bone marrow is not producing red blood cells. And you drop your calcium because you're not working with vitamin D properly. Your kidneys stop playing ball. And because of that, your body starts to go into a variety of pathologic processes. Now let's talk about the first kind of renal failure, pre-renal. It's also known as pre-renal azotemia. And any cause of hypoperfusion will cause pre-renal azotemia. Hypotension, generally systolic blood pressure less than 90, or hypovolemia from dehydration or blood loss. GI bleeders can sometimes come in with pre-renal azotemia. Patients, elderly patients who've been severely dehydrated from either infectious causes or from not having adequate water supply, such as those in nursing homes, will develop pre-renal azotemia. For those of you on the wards, you've seen this. Patients come in with cough and sputum, and they have infiltrates on the chest x-ray, and their BUN creatinine's through the roof, and so you're like, do I give hydration or not? And you hydrate them a little bit, and you notice the BUN creatinine, mwah, beautiful fix, because they're pre-renal. The last form of pre-renal azotemia is one that we always forget. Low oncotic pressure, yes, not having enough albumin. Cirrhotic patients have this problem. Cirrhosis, no more liver, no more albumin, low albumin, low oncotic pressure. So my blood vessels just not holding on to enough fluid, and so the fluid leaks out from the capillary bed, and then, oh, what happens? Hydrostatic pressure is unopposed, and then, oh, what happens? I am lipoperfusing. Yes, 3 ways to have prerenal azotemia: hypotension, hypovolemia, and hypooncotic pressure. Sure, if you want to remember the 3 hypos, go for it. Hypotension, hypovolemia, and hypooncotic pressure from low albumin in cirrhosis. What are some other causes of prerenal azotemia that we forget besides the 3 hypo? Well, there is specific diagnoses that'll do it. Congestive heart failure, not having enough cardiac output. Remember, the kidneys need 1/5 of your cardiac output to remain perfused. And so when you have congestive heart failure, if it's systolic or diastolic heart failure, you're going to have a hypoperfusion, and you're not going to perfuse your kidneys. This is a specific diagnosis in which you can have prerenal azotemia. The next is constrictive pericarditis. Again, another condition in which your cardiac output is compromised. The last one that we want to talk about is renal artery stenosis. Now, renal artery stenosis can be from 2 causes. Remember, if they're young, it's from problems in their different kinds of metabolisms, and they have fibromuscular dysplasia. If they're older, it could be from calcifications and atherosclerosis. But renal artery stenosis, in these patients, blood pressure is going to be high. But because their vessels are closed down, so blood's coming down the aorta, and boom, it's going to go to the kidney, and what ends up happening when it goes to the kidney, it's closed off. And so the kidney's thinking, hey, where's all this blood pressure? Renin-angiotensin system kick into effect. I must be hypotensive. And so blood pressure goes up even some more, and blood comes down the aorta, down. Oh, make a turn, go to the kidney. Not getting enough blood flow. Why? There's a blockage. Stenosis. Vessel small. Can't really see through it. What's going on here? I can't see through. It's supposed to be nice and big. Blood's supposed to be going to the kidneys, but it can't go to the kidneys. And so what happens? You have stenosis, and you can't perfuse your kidneys. And so the body thinks you're hypotensive. And so because of that, you develop prerenal azotemia. So how do you diagnose somebody with prerenal azotemia? Well, prerenal azotemia are going to have the following characteristics. They're going to have a BUN to creatinine ratio greater than 15:1, and often greater than 20:1. Yes, we've heard these 10:1, 15:1, 21. It sounds like you're in an auction. Can I get 21? Can I get 21? Can I get 15:1? Can I get 15:1? Can I get 21? But the fact of the matter is that they'll be greater than 15:1, and most often than times, greater than 20:1. Your urine sodium is going to be low. Your FeNA, your fractional excretion of sodium, will be less than 1% when you calculate it. And therefore, your urinary sodium is going to be low. Why? Because you're going to try to hold on to sodium. You're going to try to hold on to it. As I mentioned, fractional excretion of sodium will be less than 1%. This is basically the exact same thing as I mentioned before. Low urine sodium. You're holding on to sodium. Therefore, you're going to release less. Because where sodium goes, that's where water goes. And your body's thinking, I'm dehydrated. So let me hold on to sodium. If I hold on to sodium, I'm going to hold on to water. Remember, for every 1 sodium molecule, you hold on to 3 water molecules. Osms. Yes, we cannot be talking about nephrology unless we talk about osms. Oh, the great Osm. Osm could be in Lord of the Rings. You've got Gandalf and you've got Osm. Yes, urine osms are going to be greater than 500. And you're going to see some casts. Yes, we're going to take the urine, we're going to spin it down, we're going to take the sediment, and then we're going to look at it in a microscope. And what are we going to see from the PP? We're going to see hyaline casts on UA. Hyaline casts, yes, we're going to see hyaline casts are very, very commonly seen in prerenal azotemia. Write that down, hyaline casts. I want you guys to take a separate sheet of paper right now, because we're going to be going through talking about all kinds of casts. White cell casts, eosinophilic casts, muddy brown casts, Rolling Stones casts. No, I'm just joking. We're not going to have Rolling Stones casts. I'm sure they would love it. But you're going to have hyaline casts on the UA. And what that's going to mean is going to be telling you, oh, I'm going to be talking about a specific disease. Write this one down. Prerenal azotemia, hyaline casts. Now you might be thinking, great, I know how to recognize it. I know what it's going to look like on diagnosis. How do you treat it? The best way to treat it, well, very simply, take care of the underlying cause. That's right. You can't just say, bolus IV fluid. But what if it's not a matter of that? What if it's congestive heart failure? You give more fluids, you put them into worse congestion. Worse congestion means more compromise of cardiac output. And now you've made the prerenal azotemia worse. Remember, it's not reflexive medicine. We must think critically approach and then make a decision about the patient's best interests. And in this case, the treatment of prerenal azotemia is entirely based on the underlying cause. Now for your CCS tip, here's the best one I can tell you right now. On all CCS cases that have renal issues, you should be ordering the following tests. Number 1, a urine analysis. Number 2, order all the chemistries, electrolytes, do a comprehensive panel. And lastly, order a renal ultrasound. These are the 3 tests that they're looking for when you're doing the CCS. Now let's move on to post-renal azotemia. We're going to skip renal for now and move on to post-renal, which is known as an obstructive uropathy. Obstructive uropathy. We're obstructing the flow of PP, and therefore our kidneys are getting injured. Now any kind or any cause of obstruction of the kidneys leads to renal failure. That can be a stone in the bladder or the ureters. That can be strictures in the ureters. And that can be cancer of the bladder, the prostate, or the cervix. Now think about this. If I have a stone in the bladder that's obstructing outflow, that's going to cause backup to the kidneys. If I have stones in the ureters on either side, that means one kidney is going to have an inability to drain. If I have a cancer of the bladder, outflow obstruction. If I have cancer of the prostate, compressing the urethra. If I have cancer of the cervix, again, outflow obstruction. And these are all causes of obstructive uropathy. When you're thinking of obstructive uropathy, remember that picture, 2 kidneys, ureters, bladder, urethra. Think anywhere after the kidney from the ureters down, you can actually have an obstructive uropathy. Think of the things that can cause it. And then approach your vignette. Neurogenic bladder. Now, your neurogenic bladder, many people forget, can be a cause of post-renal azotemia. Neurogenic bladder is an atonic or non-contracting bladder. It doesn't squeeze out the urine, and this can be from diabetes and multiple sclerosis. How do you diagnose it? Well, post-renal azotemia is going to give you a BUN creatinine ratio greater than 15:1, but you also want to look for distended bladder on exam. You're going to feel a fluctuant mass over their suprapubic region, and when you press down, the doctor, that hurts. Doc, that really, really hurts. I remember when I was an intern, I went onto the wards, and I got called by one of the nurses, and she said, the patient has low urine output, we should move them to the ICU. The patient has low urine output, we should move them to the ICU. We're going to have to start dialysis. I said, hold on, I'll be right there. Remember, when a nurse calls you, regardless of what you think, you should always go and see the patient. That one time you don't could be lethal. Regardless of what you think is going on, whether you believe it or not, go and see the patient. So I went to go see the patient, and I said, sir, how are you feeling? Doc, I've got some pain. This is the worst pain. I just can't figure out what it is. So I go and I examine him. Start from head to toe, and I begin examining the patient. And as soon as I begin to palpate the suprapubic region, what do I find? Ah! He starts screaming. He says, it's so painful. I said, sir, when was the last time you went to the bathroom? Because I could feel this cystic fluctuant mass. I knew it was his bladder. He says, I can't really remember. I think it was before I got here. I looked at his tag. That was 2 days ago. This guy's bladder was probably up to his nipples. And so what did we do? We went ahead and placed a Foley, and over 1.5 liters of urine came out. And what did he say? Ah, thank you. Yes, that's what they're going to tell you. They're going to say, ah, thank you. That is not a pathognomonic sign for post-renal azotemia, but on the wards, this is what happens. Now, you're going to have large volume diuresis after you pass on the urinary catheter. This is because the kidneys are recovering, and so they're going to diurese very, very fast. And you might even see on ultrasound bilateral or unilateral hydronephrosis. And that's basically because the urine, from wherever point of obstruction there is, backs up. It goes into the ureters distend, it goes up to the calcule collecting system, and they start to descend, and you start to see hydronephrosis. So, what does hydronephrosis look like? Well, I'm off the screen. I know you're going to miss me. But let's look at the left side. On the left side, you actually have a stone in the ureter where the arrow is pointing to. Here is an axial cut. You see both kidneys. Notice how the kidney on the right side of your screen, or the left of the patient, is actually far more distended. It's far bigger. So much bigger, in fact, isn't it, than the one on the right? And that little arrow that's pointing there is a stone. And that stone is actually at the neck of the collecting tubule. Now let's look at the actual collecting tubule system. On the right side of your screen, you actually see the differences in the kidneys. You can see that the kidney on the right of your screen, or the left of the patient, There's hydronephrosis. The calculal collecting system is distended, it's fat, it's obese, it's full of urine. But look at the contrast. Do you see contrast where the ureters are supposed to be? Do you see contrast going into the bladder? No, you don't, because that's where the stone is, and this is what a unilateral obstruction will look like. Now let's keep going. This is a person who has a stone in the ureter and a stone in the bladder. Look at how distended that bladder is. It's taking up the entire abdominal contents, and that is an extremely painful event. Now here's something that you guys have to remember. Now obstruction must be bilateral to cause renal failure. That's right. Obstruction must be bilateral, because what happens if one kidney is not working well, the other one still works, so you still clear out BUN and creatinine. A unilateral obstruction cannot cause renal failure. So your BUN and creatinine will not be affected. Remember these little facts, because they're going to tell you on the exam, Dr. So-and-so, we're giving you a patient. The patient has a unilateral obstruction. Will this cause renal failure? And you have to say no, because bilateral obstruction can do that. Because remember, one kidney is still functioning, so it will still clear out the BUN and creatinine, and so your kidney function will still remain intact. Now let's move on to the third type of kidney failure, and that third type of kidney failure is parenchymal, or at the level of the kidney. We did pre-renal, before the kidney. We did post-renal, obstruction. Now let's move on to the actual kidney. Let's talk about the kidneys. Let's talk about kidneys, baby. Let's talk about it and you. Let's talk about all the bad things and all the good things about renal failure. Now, BUN to creatinine ratio is closer to 10 to 1. This is the only time I mentioned 10 to 1. Remember, 15 to 1 to 20 to 1 pre-renal. Greater than 15 to 1 post-renal, but closer to 10 to 1 is an intrarenal cause of renal failure. The urinary sodium is going to be greater than 40. Keep that in mind. And lastly, the urine osms are actually going to be less than 350. These are all very, very strict points. You might be thinking, well, could they be different? Yes, but remember these numbers. These are going to be guide points for you to be able to decide whether this is intrarenal, pre-renal, or post-renal. Now let's talk about some causes of intrarenal failure. The first is acute tubular necrosis, the very feared ATN. Yes, when you're a resident, you fear ATN because now you know this person is going to be in for a ride, this person is going to have a tough time in the hospital, they're going to have an extended stay, length of stay goes up, they're going to have a tough, difficult hospital course. Or as we write on the transfer summary, patient had extended course in hospital, tumultuous. Hypoperfusion to the point of death of the tubular cells. ATN is when you drop your blood pressure so low, you actually infarct your tubular cells and they just slough off. They slough off, and now they don't do their job anymore. And so you can't filtrate, and you can't reabsorb, and you can't secrete, and without your tubules, you're not producing urine, and now you've got a big problem. You're an ATN. Hypoperfusion can cause ATN. Toxic injuries can cause ATN. Imagine having too much vancomycin around. Yes, too much vancomycin floating around. You didn't check a level for 3 weeks. Patient's been in the hospital getting treatment. And all of a sudden, you decide, hey, I think I'm going to check the vanco level. Vanco level's through the roof, and you start to wonder, why is this guy, is the renal failure not getting better, and what's going on with his urine output? Toxic injury. Yes, there are a lot of medications that can do this, a lot. I picked vancomycin just because a few months ago I was rounding, and we came across a patient from another team, and we started seeing that there was some issue, and that was similar. The patient had ATN from vancomycin. The problem here, though, is that the patient is getting antibiotics that are so powerful and so heavy duty that it's going to cause kidney injury. They're probably extremely, extremely sick to begin with. And so they're probably also hypoperfusing from vasodilation, from toxic metabolites and toxins from the actual bacterium. So it's usually a combination of two. Now let's move on a little bit more to toxin-induced renal insufficiency. Here's the problem with it. There's no test to prove a particular toxin caused the renal failure. What we can do is know the common causes, because that's what they're going to test you on. Common causes are aminoglycosides, such as gentamicin, tobramycin, and amikacin. Oh yes, the aminoglycosides really bang up your kidneys left and right. The next one is hypomagnesemia, by the way. Let's move back a second. Hypomagnesemia is actually suggestive of aminoglycoside-induced renal failure, but it's not conclusive. So if they tell you the patient's magnesium level is low and they've got some form of intrarenal process going on, your mind should be going off to think that there's a toxin-mediated renal insufficiency here. amphotericin, contrast agents. Oh yes, we all know about the contrast agents. When we went through residency, every time a patient went for CAT scan, our patients would say, well, I need to sign this form, right? Yes, you have to sign this form. Well, what do I have to sign this form for? Well, in case we destroy your kidneys, we don't want to have the hospital be liable. Yes, contrast agents, when you do a CAT scan, can actually box your kidneys. Where did that term even come from, boxing your kidneys? Because of boxing. We're going to have two kidneys, and we're going to go, all right, here's a little contrast, bam, 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 oh, there goes one. And then we're going to get a little amphotericin, boom, 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 and we box the other kidney. And what ended up happening? Toxin-induced renal insufficiency. That's where the term boxing your kidneys came from. The next one is the chemotherapeutic agents. The one that the boards love to ask you about is cisplatin. Make your kidneys go splat. That's right. The mnemonic is true. Cisplatin makes your kidneys go splat. It's like someone took one and just splat it against the wall. So how do we diagnose it? Because remember, we said there's no specific test that tell you that there is a toxin-mediated renal insufficiency. There's no current test out there. And if you can find it, email me, because we'll market the heck out of it. But that's aside. Now, the UA is one particular way that helps. The UA is going to show a muddy brown cast or granular cast. They almost look like sand. And what is this? The muddy brown cast are the actual tubules coalescing together and turning into these casts. Remember, the worst part about toxin-induced renal insufficiency is there's no specific therapy to reverse toxin-induced renal failure. So how do we fix it? Remove the toxin. Now let's talk about ATN and the muddy brown casts, the muddy brown casts of ATN. Here we go. Look at them. Look at it where they're just popping up. This is what a muddy brown cast looks like. In the top left of your screen and the bottom, these are different urine analyses that have been spun down by centrifuge. The patient will urinate, and then they will take the urine that has been collected. They may not have a lot of urine output, but whatever urine output you can get from their Foley bag, you will go ahead and spin it down and centrifuge it. And in the bottom, you'll notice that there's going to be cells, there may be some even blood cells, but you're going to go ahead and take it and smear it across after you pipette the sediment. You're going to smear it across and look at it under a microscope. And this is what you're going to see. You're going to see these muddy brown, granular looking casts. They almost look like if you were to rub your finger against them, they feel granular and almost like sandpaper, don't they? But if you don't believe me, this is what ATN looks like on a microscope. This was a patient that we had many, many months ago. This patient came in and was just in frank renal failure. And when we went ahead and checked his urine analysis, the urine analysis read came back and said, muddy brown casts are pan-apparent. Pan-apparent meaning they're everywhere. This person had massive ATN, and because of hypoperfusion, he was septic. So let's talk about this man. A man is admitted for pneumonia from a nursing home. He's placed on piperacillin tazobactam, and he becomes afebrile. Great, we're treating the pneumonia. He's doing better. 2 days later, however, his BUN and creatinine start to rise. Uh-oh. The intern picked it up in the morning. He told the resident. And he now starts to develop a new fever and starts developing a rash. Is it itchy? We don't know. But what's the diagnosis? And what is the most accurate diagnostic test to find out what is going on to this guy's kidneys and why is he having fevers and what is this rash from? The answer? Allergic interstitial nephritis. That's right. He had a hypersensitivity reaction to mediators, the most common being penicillin or sulfur drugs. Now, other common culprits are phenytoin, allopurinol, cyclosporin, quinidine, quinolones, or rifampin. Remember, rifampin is not just known for orange urine. It's also known for allergic interstitial nephritis. So what do you want to look for in a patient that has allergic interstitial nephritis? Well, you want to see BUN and creatinine going up, but you also must see a fever and a rash. The UA is going to show white cells. And when you do a Wright stain or Hansel stain, these are the two stains that are very specific. They're going to show positive eosinophilia because it's an allergen, and eosinophils and allergies go together. No specific therapy, though. Get rid of the agent, and the therapy is just let it resolve on its own. If you remove, in this case, the piperacillin tazobactam, over time this person's renal function will start to climb, and over time the rash will dissipate and the fevers will go away. But for those of you who've never seen a Hansel stain, here it is. Hansel stain stains eosinophils, and you can actually see them just all modeled together right over here. These are all the little eosinophils modeled together, and then they're casted together because the tubules are a tube. And so all those eosinophils get in there, and then they fall right out, and you see it on the UA. Now, one thing I have to tell you guys, everyone thinks about cyclophosphamide, hemorrhagic cystitis. Cyclophosphamide, hemorrhagic cystitis. Cyclophosphamide, hemorrhagic cystitis. It has been drilled into us since step one, hasn't it? But here's the thing. it doesn't cause renal failure. Hemorrhagic cystitis, fine, I'll give you that, but not renal failure. Here's one thing that happens. They'll actually tell you on the USMLE, cyclophosphamide, patient has bloody urine. What's going on? And one of the choices will be hemorrhagic cystitis. But some of us get a little tripped up. We'll see the BUN creatinines through the roof. But is that renal failure? Yes. Was it from the cyclophosphamide? No. Cyclophosphamide does not cause renal failure. You must avoid this frequent wrong answer. Moving onward, rhabdomyolysis. Now, rhabdo is a large volume muscular necrosis, and it's the direct effect of myoglobin on kidney tubules. The myoglobin jams up the kidney tubules. In rhabdo, you want to look for crush injuries, guys or women or anyone who've gotten caught under large, heavy objects. They've gotten their hand caught in construction work, or their bodies have gotten caught under a pileup. And you're going to look for patients who've even had seizures, and massive contraction will actually cause leakage of myoglobin from all of their muscles and cause clogging of their kidneys, or prolonged immobility in an intoxicated patient. Most commonly, the USMLE is going to say a homeless person intoxicated is brought in, and FYI, this is what we found. So what is these FYIs you're going to find? Well, we'll tell you in a second. The last one that really likes to come up on the USMLE is a patient who's been recently started on a statin medication from myositis and leakage of myoglobin. So what are you going to look for? You're going to diagnose them by the best initial test being a urine analysis. Look at that. We're in nephro. We're going to do urine analysis. Who would have thought it? The dipstick is going to be positive for large amounts of blood. Large amounts of blood. The dipstick, remember, that doesn't tell you numbers. This little dipstick goes right into the urine. But when you then send the reflexive urine analysis, reflexive, because when we get a sample, we send it to the lab, they do a dipstick, and they say this, and was found. Certain things tell them automatically go and do a urine analysis. And when they do the urine analysis, they'll say no cells were seen on microscopic exam. So where did all this large blood go? And when you do their chemistries and you order a specific test, the CPK levels are going to be elevated, massively elevated. The most accurate diagnostic test is urine myoglobin. Now here's what's going on. When you have brown urine in rhabdo, right here, you see the brown urine in rhabdo. Most of us would think this is blood. The dipstick even says there's blood, and we'll think blood. Right here, I gotta move a little bit. Right there, blood. Dipstick says there's blood, but what's going on? In rhabdomyolysis, what ends up happening is myoglobin makes our dipstick go bing, 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 we have blood. But the problem is it's not red blood cells, it's a false positive. And so we think there's blood. It even looks blood because of the dipstick, but you won't see red cells. Whenever they tell you, and this is a classic finding on the USMLE, the dipstick shows positive blood, but on your microscopic examination, no red blood cells were seen, you should be thinking rhabdomyolysis. You should be thinking myoglobin. Order the most accurate test, which is urine myoglobin. Make the diagnosis, move on. What are some other things you should order on the CCS? Because remember, in MCQ, they're only going to tell you certain things. But on CCS, you've got control. You should order a potassium level because they're going to be hyperkalemic, possibly from crush injury. Their calcium levels should be also ordered because they'll be low. Yes, hypocalcemia. And they'll be hyperphosphatemic. And lastly, they're going to have decreased serum bicarb. Remember, myoglobin is an acidic component, and therefore their bicarbs are going to be low because they're going to be fighting this acid-base battle. How do you treat them? Very, very carefully. Bolus of normal saline, not IV fluid hydration, but bolus of normal saline. Yes, blast them with fluids. Don't just start the little 80 cc's of maintenance fluid, or what we like to call gentle hydration. What is gentle hydration? Is that like, okay, it's okay, I'm going to give you a little IV fluid, it's gentle, it's okay, it's tranquilo, don't worry, don't worry. No, no. You're going to give them bolus of normal saline. Flood them, because you need to unclog those tubules before it gets very, very advanced. And we want to give mannitol. Now, why do we give mannitol? Mannitol actually causes us to have decreased contact time of myoglobin with the tubule. And that's what we want, because the myoglobin is toxic to the tubules. And lastly, we want to alkalinize the urine. How do we alkalinize the urine? Well, we give them bicarb. And what this does is decreases the precipitation of myoglobin at the tubule. Again, we're trying to save the kidneys, flushing the kidneys, decreasing the contact time with the kidneys and the myoglobin. And lastly, precipitation of myoglobin tubule decreasing. We want to try to do all these things because we want to save the kidneys, because myoglobin is just so toxic. Next question. A patient is brought to the ED after seizure, leading to prolonged immobility on a sidewalk. Why was he on a sidewalk so prolonged? Maybe he was intoxicated. Maybe he passed out after a seizure. In this case, that's what happened. Or maybe it was a combination. He has dark urine and myalgias. What is the most urgent test for this patient? Well, go ahead and pause me and figure it out. All right, let's go back to it. Now, if you chose choice C, EKG, you're absolutely correct. Here's why we have to choose EKG, because these patients, after having these massive release of toxin and myoglobin, are also hyperkalemic. And we want to make sure that they're not having peak T waves and having abnormal arrhythmias from that. So we want to make sure that their EKG is okay. If they're okay, then we can progress. But the most urgent next step is an EKG. Now let's move on to crystal-induced renal failure. Yes, we actually have crystals. We have oxalate crystals, so we want to look for suicide by antifreeze or ingestion of ethylene glycol. This patient will be intoxicated, and they're going to have metabolic acidosis and an elevated anion gap. Remember, it's an anion gap metabolic acidosis. Diagnostic test of choice for these people, the best initial is a UA. That's right. We're doing nephrology, do a UA. If you're doing hematology, do a peripheral smear and a CBC. They go together. Now, on the UA, you're going to see envelope-shaped crystals. And how are you going to treat them? With ethanol or fomepizole with immediate dialysis. Ethanol or fomepizole with immediate dialysis. Now, for those of you who've never seen a calcium oxalate crystal, there it is. You see that one on the bottom right? Why am I even telling you to look at it? Look right there, envelope shape. You see it looks like a little envelope. It looks like a letter to Santa. Yes, Santa Claus, I would like a pony for Christmas. Yes, right there. You've got your envelope-shaped crystal. Now, crystal-induced renal failure are going to also present with uric acid crystals. And in these patients, if you see uric acid crystals, you're going to want to look for tumor lysis syndrome after chemotherapy for possibly lymphoma in the history. How do you treat them? Well, you treat them with hydration, ribiricase, and allopurinol. Let's get rid of that uric acid. Let's hydrate them. Another form, again, was the uric acid crystals I want to show you, and here they are, right there, uric acid crystals. Now, contrast-induced renal failure is a very straightforward one because they're going to have to tell you the patient had a radiologic procedure with contrast before in the history. If they don't tell you that, where the contrast come from, correct? It's going to be an elderly patient. Another risk factor is they're going to have hypertension and diabetes, so their kidneys have already taken a beating, and they're going to have some mild renal insufficiency at baseline. The typical creatinine that you're going to want to look for is a baseline of about 1.5 to 2.5. These are all risk factors: elderly, hypertension, diabetes, and mild renal insufficiency. All these things put together puts you at risk for contrast-induced renal failure. So what's the best method to prevent contrast-induced renal failure? The answer? Hydration with normal saline. Yeah, just hydrate them before, hydrate them after, get that contrast, get those kidneys going, and the contrast will flow right out. In some patients, however, you might need to use bicarbonate, N-acetylcysteine, or even both. Now, step 3 wants you to know every single slight elevation, even a slight single elevation. Every time you have a slight elevation in creatinine, that's actually a loss of 60 to 70% of your renal function. That's right, a little bump. You know how we say the creatinine bumped a little bit? Well, that bump is 1,000 neurons going, they blew up. They're gone. They're not going to work anymore. They're on strike. And so when these nephrons are on strike, you lose function. Yes, that's right. This neuron, that neuron, this neuron, that neuron. All these neurons are not working, and so you've lost anywhere between 60 and 70% of renal function. Now, one thing that we must always remember, we have a lot of aging population. In fact, in the United States, our population is aging very, very quickly to the point where that's the majority of our patients. And so they take a lot of NSAIDs because their elbows hurt, and their hips hurt, and their knees hurt, and their ankles hurt. And they shouldn't be in pain, so they take NSAIDs. But what they don't realize is that NSAIDs hurt their kidneys, and they hurt their stomachs. But right now we're in nephrology, so NSAIDs hurt their kidneys. Why? Because they are directly toxic, and they can cause ATN. And when they start hurting the kidneys, they can even cause allergic interstitial nephritis with eosinophils in the urine. So now you have a direct toxic effect, possibly causing ATN, or possibly causing allergic interstitial nephritis. And that's not all. You can even have nephrotic syndrome, and you can even have afferent arterial vasoconstriction and decreased perfusion of the glomerulus. Why? Because prostaglandins are responsible for the afferent tubule. And if I block them with an NSAID, you're not going to have that perfusion that you need, and you're going to have renal failure, and you're going to have hypoperfusion. Ladies and gentlemen, that is the first chapter right there. We are done with acute renal failure. We're going to be back at chapter 2 where we talk about glomerulonephritis.